Good evening, everyone, and thank you for joining in. My name is Dr. Sona Warrior from the medical team of USV, and I welcome everyone to yet another insightful session of Dr. KK's Med Talks. In today's session, we are going to be talking about the wonder drug in diabetes treatment, metformin. After a history of over 60 years with moments of spectacular victories, metformin can now be regarded as a universal remedy. Its therapeutic magic is being increasingly appreciated not only in the background treatment of diabetes and prediabetes, but also in reproductive pathology, cancer, cardiovascular diseases, and anti aging. Therefore, to enlighten us more on this subject, let me welcome Dr. R. Santosh, a renowned consultant endocrinologist from Hyderabad. Dr. Santosh is the Executive Director at Magnacode Healthcare and Research Private Limited, Hyderabad. He is also associated with Fernandez Hospital and Apollo Hospitals, Hyderabad, as a consultant endocrinologist. Thank you for being with us, sir. It's an honor. Without further ado, we'll just jump into the chat show that we are here for. The first question to start with, let us address this very contemporary topic of debate. Despite a long-standing history of metformin use, there is always a discussion regarding whether metformin should continue to be the first choice of therapy in type 2 diabetes. What are your thoughts on this thing?
Yeah, actually, to answer this question, let's just remind our audience about what the basic pathophysiology of type 2 diabetes is. So, the basic pathophysiology, if everyone knows here, we have an august audience. It is, in fact, insulin resistance or the inability of the insulin to shift the glucose from the blood into the peripheral tissues. This, in turn, leads to an increased hepatic glucose output. And if you see metformin is actually addressing the basic pathophysiological mechanism of type 2 diabetes. So it's a no-brainer, actually. So if you are having something which affects the main pathophysiology of a particular illness, we should use it as a first-line agent. Metformin, because it affects the insulin resistance per se, it can be used in a wide variety of conditions that lead to diabetes also. So I'm sure we will be discussing about PCOS in the future, but there are a lot of data to suggest that metformin can be used even before a person develops type 2 diabetes, that is diabetes prevention as well. So a person who's having impaired fasting glucose or impaired glucose tolerance, also we give metformin. And a person who's having an HbA1c of 8 to 8.5, also we give metformin because the basic pathophysiology is taken care of. The wonderful advantages of metformin as a first-line agent is, let's be very frank, okay, it is one of the most inexpensive molecules that are available in the market, not only in India, even in those markets that are actually covered by insurance. They will always prefer it because of its inexpensiveness. You know, there was a CME where I used the word metformin is cheap, and there was a doctor who got up and said, how can you say metformin is cheap? That is not a correct word to use. Ever since, this happened around 11 years back, okay, and ever since, I am also very careful. I don't use the word cheap. I say metformin is inexpensive, which it is. So metformin is inexpensive, and the most important thing is it addresses the pathophysiology of type 2 diabetes. Because it does that, you can use it at a wide range of HbA1c. So HbA1c of 6.1 pre-diabetes, you can use metformin. Above 6.5, you use metformin. Even up to an HbA1c of 8, you can use metformin, because it has something called as a thermostat effect. This is what I tell my patients also. What is a thermostat? Basically, in a geyser, when the water is becoming very hot, the geyser stops working. So metformin knows when to start working, when to stop working, because it's not increasing the insulin secretion from inside, is it not? It knows that, okay, when the HbA1c is 8, I need to work this much. When the HbA1c is 7, I need to work this much. When the HbA1c is 6.5, I need to work this much. So metformin in that way also is very good, because it will never cause hypoglycemia, because it's not doing anything directly to the insulin secretion. And the great thing about metformin is, leaving aside the 5 to 7% of patients who can't tolerate metformin, everybody can tolerate it quite well. And it also helps a little bit in weight loss. And also it has some data as far as cardiovascular protection is concerned. I don't see any reason why metformin should not be used as the first line agent. It has all the qualities that make it ideal for use as a first line agent in diabetes. And that's what is endorsed even by the American Diabetes Association, the NICE guidelines, the EASD guidelines, and of course, the RSSDI guidelines in India also suggest that metformin only should be the first line.
Thank you, Dr. Santosh, for that very insightful answer. I mean, the analogy of the thermostat was quite catching, and that's how maybe we'll remember metformin now. Now that you have established the use and the benefits of metformin as the first line, just wanted to know from you, from your experience, how do you place the doses of metformin? What is the what does it work better in a submaximal dose? How to minimize the side effects when it is escalated and optimized to the highest dose?
So the amazing thing about metformin is it has no recommended dose. So we usually start with a dose of 500 milligram twice a day in most people, and in those people who are having known GI issues, we probably start with a lower dose, 250 mg or 500 mg once a day. So 500 mg twice a day is something that we start with. Well, how do I initiate my conversation with any patient whom I want to start metformin, let it be type 2 diabetes or even PCOD patients? I say that when you start metformin, you are probably going to have some upset tummy symptoms. Basically, you might have a little bit of acidity or a little bit of bloating or a little bit of nausea in the first few days of use of metformin, which usually goes away after 3 to 4 days of use. If you're finding these side effects quite difficult, instead of using it twice a day, please use it once a day for some time and then hike it up to twice a day. That's what I tell most of my patients. And all of them are able to tolerate it that way. Even in
Right.
literature and even in our day-to-day practice, we are seeing around 5% of patients, they can't tolerate metformin at all because they continue to have GI side effects, especially acidity and in some patients diarrhea actually. So in those 5% of patients, they are the unfortunate people who cannot be given metformin for the management of type 2 diabetes, because I tell everybody metformin is the pillar in the management of diabetes. It's the thumb of treatment actually. We tell that if metformin is not there, it's an unfortunate thing that you can't tolerate it. We'll have to look for alternate treatments which will help you. And so 500 mg twice a day is what we start. It's very efficacious in most people. Increasing doses of metformin will definitely help in improving the efficacy. It's not that suboptimal dose is the one which is going to help. So a person who is not getting an adequate fasting glucose control, especially fasting blood glucose, you can hike up the dose to 850 mg. You can use it 1 gram twice a day. Majority of the patients who tolerate metformin, they can use a good dose of up to 2.5 grams per day also. That is the highest recommended dose, because about 2.5 grams per day, metformin probably will not affect that much. So you can hike it up slowly to a dose of around 1 gram twice a day. That's what I give for maximum number of patients. I don't usually go up to 2.5 grams per day. But yes, we start with a lower dose. Depending on the tolerance, we can hike it up depending on how much the sugar needs to be controlled.
Yes, sir. So I think that's a good news that the prevalence of these side effects is quite low, or the intolerance of metformin is quite low in clinical practice, and there are strategies to minimize the side effects as well. So that's good. You had mentioned about the extra glycemic benefits of metformin. So one of the what do you say? The off-label use of metformin is in obesity also. So what do you, according to you, what are the benefits of metformin in obesity? Which patient profiles, and if metformin works in an obese patient, can lean diabetes people can they also benefit from this drug when weight is an issue?
So, and as an endocrinologist, we do see many patients with obesity, and it's very fair to say that obesity, the leading cause of obesity, also is insulin resistance. So, let me just explain like how I would explain to a patient. So, insulin resistance is a condition which is precipitated by a family history of diabetes. It's precipitated by lack of exercise. It's precipitated by mental stress and irregular eating habits. That is, eating less during the daytime, more in the nighttime. 5 days you eat less, 2 days you eat more. Insulin resistance occurs because of these major risk factors. So obviously, for management of obesity, we must tackle the main four things. That is diet, exercise, sleep, and de-stressing yourself. But if you want to have a little faster weight loss, we must give some agents which will help you to reduce this insulin resistance. So how does insulin resistance cause obesity? Insulin resistance is a condition where the insulin does not work properly. And therefore, if the sugar has to be normal, everybody has to produce this much insulin. In an insulin resistance person, this much insulin is not enough. So they end up producing this much insulin, The sugar remains normal, but that excess insulin is the one which is causing certain problems. Excess insulin causes especially deposition of fat in the visceral areas, basically in the abdominal area, and
Yes.
in gents it causes weight gain in the chest area, and in
Okay.
most people it causes weight gain in the shoulder area and neck area as well. That's where you put on weight if you're insulin resistant, and this seems to be the leading cause of obesity. So, giving metformin will directly address the insulin resistance along with diet, exercise, good sleep, and de stressing. Only metformin is not going to help for obesity. That's 100% sure. Many patients, what they do is they take metformin and they continue to eat their ice creams and biryanis, and nothing happens to them, and they blame that. So, if you are
Right.
able to diet, exercise, taking help from metformin to reduce the insulin resistance will help in weight loss, and therefore, for obesity management, many endocrinologists we still use metformin for the along with lifestyle modifications. That's very important. Metformin, as we know, it does cause a little bit of reduced appetite also in most people. This effect is seen very well in pregnant women. So pregnant women, they continue to gain weight, and then the
Right.
moment we add metformin, the maternal weight gain stops and the fetus continues to grow. So therefore, metformin is one of the greatest signs of anti-obesity is in a mother actually who's continuously growing weight. Suddenly she'll stop growing weight because of metformin use. So we do use metformin for that sense also, but mainly for insulin resistance reduction we use it. You were talking about a lean diabetic. So when you come to a lean diabetic, we always mention about this particular photo that was published in Lancet. That is the Utin and Yagnik photo, it's called. So Utin is a person who is from Russia, and Dr. Yajnik, as we know, is a very famous person who works in diabetes from Pune. And you can see they have taken one photograph. Both of them are sitting next to each other. Mr. Utin is looking like a huge fellow in front of Mr. Yajnik. But when they checked the body fat, the BMI of Mr. Utin is greater, for Mr. Yajnik is lesser. But body fat for Mr. Yajnik is much more than what it is for Mr. Utin. So what that came across is that Indians are having something called as visceral or adiposity. We are the thin fat individuals. We look thin, but actually we have a lot of fat, especially in the around the visceral organs, around the liver, around the pancreas, around the stomach. That's where all our fat gets deposited. So especially in Indian lean diabetics, metformin will continue to work. Metformin will work excellently even in Indian type 2 diabetes. So it's not that only obese type 2 diabetes are supposed to take metformin. Even lean type 2 diabetics need to take metformin. And it's not uncommon to see many Indian patients who are actually lean and also have type 2 diabetes. Metformin should be the treatment of choice for them as well.
Right, so thank you. This is, as as you said, first of all, thank you for clarifying and simplifying the mechanism of metformin in obesity. And as you said, that lean diabetes at the end of the day is still a diabetes per person. So metformin, the mechanism can be used for reducing the visceral fat, visceral adiposity, and that's and eventually reducing insulin resistance. So yes, thank you for elaborating that. The next question I have that is, so diabetes is always a heart disease equivalent. CAD is the heart of the matter in diabetes, and we have several comments or several reports in the literature about metformin use in CVD patients. So I will be saying two statements. I want your thoughts on the same. So for the first statement is, in the reports it says metformin reduces cardiovascular mortality, all cause mortality, and CV events in CAD patients. So what do you have to say about that?
See, yes, let's be very frank. We don't have something called as hard data with metformin because metformin never required the need for going through such a rigorous trial like what is required with the SGLT2 inhibitors and what is required with the GLP-1 receptor agonists and DP4 inhibitors. Metformin, when it was approved in the US, it never had to undergo a cardiovascular outcome trial. So whether it actually reduces the mortality or morbidity in CAD patients, we don't have a hardcore answer for that. But metformin, let's see, since the approval of metformin, people have started living longer. Now, please let us take it as a very simple analogy. Since metformin and statins entered into the market, The average life expectancy in India was around, say, 55 to 60 years. Now it has already become 65 to 70 years. That is a very simple way of telling that metformin usage in people who are having type 2 diabetes is leading to increased life, and therefore cardiovascular outcomes are improving because of the use of metformin and statins. Okay, let's not talk such crude. Let's talk more of science. There are a lot of data with metformin with soft cardiovascular outcomes. There have been trials which have shown very clearly that metformin has antiplatelet activity, and therefore there is a definite mechanistically there will be improvement in the cardiovascular outcomes after an MI. If metformin is supposed to have fibrinolytic activity, therefore again there should be a good outcome in patients after a myocardial infarction with metformin. Metformin reduces inflammation and CRP, where therefore the second atherosclerotic attacks don't occur. And obviously metformin helps in reduction of weight as well. It controls the major risk factors in diabetes, that is blood sugar. Blood sugar also will help in prevention of cardiovascular events, and therefore it is safe to say that metformin actually is a useful drug in patients who are either having a myocardial infarction or who are having high risk for developing the same.
Right, sir. Thank you. Thank you. I think I agree with you when you say that metformin does not have a CVOT, but still the cardio safety, cardioprotective actions of metformin is well known and well celebrated, and that's why we still use it as a background therapy in type 2 diabetes, considering the long term effects. So yeah. Now coming to another metabolic disorder, that's PCOS, and it is observed now that there's a high prevalence of type 2 diabetes in women with PCOS as well. What do you have to say about the use of metformin in PCOS? Does it better the PCOS symptoms, and does it delay the progression to type 2 diabetes if the person is at high risk?
Okay. So actually, PCOS and metformin is something that I've been really passionate about. I've been working quite a bit about metformin and PCOS in general, basically. So I'm very happy that you actually asked me this question. So let's put it in perspective. PCOS is a condition which can present at any age. It can present with childhood obesity. It can present with dermatology conditions like hirsutism and hair fall and acne. It can present with gynecological conditions like irregular periods or menorrhagia. It can present with infertility. It can present with metabolic complications, like how you said, the increased risk for cardiovascular disease and type 2 diabetes. PCOS is caused by what? PCOS is also caused by the same old insulin resistance that we have been talking about. So as I said, insulin is being produced in the body. It's not able to act properly, and therefore the body compensates by producing excessive insulin. There are 3 areas in the body that are not insulin resistant. So we keep telling this to the patients also and to our students also. One of them is, in fact, the abdominal fat. Second is skin in the folds in the body, for example, around the neck, in the knuckles, in the
Okay. Right.
elbows, in the underarms. So if there is excess insulin, they'll tend to become dark over there, acanthosis nigricans. And
Right.
excess insulin directly affects the hypothalamo-pituitary gonadal axis, leading to PCOS in young girls. So if you take mechanistically, metformin is one of the best treatments for PCOS. But the problem is PCOS is not such a simple condition. You don't just treat the cause and see the response immediately. So depending on the concern of the patient, metformin is prescribed. If the concern is hirsutism and acne, metformin is not going to help because we need to do something to control the male hormones in that particular patient. We
Right.
ask them to do good lifestyle measures and diet and exercise, and then we give them OC pills for their hormonal control and ask them to visit a dermatologist.
Right.
For other conditions, for example, ovulation induction and for pregnancy, infertility, metformin is very useful. So clomiphene is the medicine that we use for ovulation induction. But if you combine clomiphene with metformin, there are so much data that metformin will improve the effect of clomiphene and improve the live pregnancy rates and improve healthy babies also. Metformin, another indication for PCOS mothers who are undergoing infertility treatment, is to prevent miscarriage. So once they become pregnant also, the first 12 weeks, if you continue to use metformin, at least because of PCOD, they won't experience miscarriage. The
Right.
third most important effect of metformin in women who are planning pregnancy, who continue to use metformin perhaps for the first 12 weeks of pregnancy. The first 12 weeks of pregnancy is dicey. Some people like to use, some people don't like to use metformin. But if you do use, there is definite prevention of gestational diabetes as well, because gestational
Nice.
diabetes is also precipitated by the same insulin resistance that is
Yes.
causing PCOD in the first place. Yes, for metabolic management, for weight loss, for visceral obesity management, and prevention of type 2 diabetes, by far metformin seems to be the strongest treatment. All women with PCOS who have impaired fasting glucose or impaired glucose tolerance should be encouraged to use metformin for prevention of diabetes, because it addresses not only the pathophysiology that leads to diabetes, it also helps in improvement of the PCOD outcomes. So use metformin judiciously. I mean, use it in women who really have concerns which can be improved with metformin. For example, fertility, for example, prevention of miscarriage, for prevention of gestational diabetes, and prevention of type 2 diabetes in the near future. All women with this spectrum of PCOD will benefit with metformin. They should be given metformin. There are some specific women like who only have irregular periods or only have unwanted hair growth or hair fall. Perhaps they won't benefit so much with metformin. They should be given a more specific treatment along with diet and exercise. So metformin is given, perhaps I would say in my practice, I would give it for at least 40 to 50% of women with PCOD for their its various metabolic benefits and benefits on live birth rates.
Thank you, Dr. Santosh. I think, I mean, to listen from you with that conviction, who's as so passionate about PCOS and metformin, so that what do you say, reinforces our belief in this drug. And thank you for even categorizing these patient types. Where metformin is needed and where metformin is not needed or will not benefit. So I think that was very clear here. Thank you. So studies have also revealed that there is an association between T2dm and Nafld. In such cases, is metformin an ideal choice for patients with diabetes and Nafld?
Yeah. So if you go back to the pathophysiology of NAFLD, also again we come back to the same old diagnosis. Insulin resistance, my professor used to say it is the common soil basically. I mean, he used to not say, he himself has quoted somebody else. Insulin resistance is something called as a common soil hypothesis. It leads to type 2 diabetes, hypertension. It leads to dyslipidemia. It causes worsening of abdominal obesity, PCOD, NAFLD, your obstructive sleep apnea, and cancer also in future. So many things is led by insulin resistance. Metformin is the one drug which addresses insulin resistance very appropriately. And therefore, NAFLD will definitely improve with the use of metformin. The problem with NAFLD is we don't have long-term studies in following patients who are using metformin. Therefore, it is not like a stamped and approved indication that metformin will actually work in NAFLD and all NAFLD patients should be using metformin. NAFLD, I'll tell you, the main problem is any drug which needs to show improvement with NAFLD, we need to do a liver biopsy before treatment, and maybe 6 months to 1 year after that we need to do a liver biopsy. That's the only way you can prove that it's working in NAFLD. But logic and good clinical sense says that diet, exercise, de-stressing, and metformin, the same four combination which I have been talking about since the beginning of the talk today, if you do these four things, NAFLD will definitely improve. Of course, we have to be a little bit careful about the fact that if a patient is going towards decompensated liver disease, metformin is contraindicated. So we cannot even give metformin if the SGOT, SGPT is going up and the patient is developing some signs of encephalopathy. So mild signs of encephalopathy, you're not supposed to use metformin at all in those patients. But those
Right.
patients who are having grade 1 fatty liver, grade 2 fatty liver, you can use metformin. There have been some studies with FibroScan showing that metformin does help in NAFLD. But as I said, liver biopsy proven studies for the long-term use of metformin is not there. But good clinical sense says that metformin will help in NAFLD, and probably you should use it, especially in type 2 diabetic patients and dyslipidemic patients with NAFLD. You should use metformin.
Right, sir. Thank you. You had also mentioned about obstructive sleep apnea. How how does metformin work in Oasis?
So one of the main pathophysiology of obstructive sleep apnea also seems to be central adiposity. And central adiposity is caused by what? The same thing again, insulin resistance. So central adiposity, deposition of fat in and around the visceral organs, which includes the pharyngeal and laryngeal fat, is dependent on insulin resistant related pathophysiologies. So metformin therefore is supposed to reduce this pathophysiology. There have been at least 3 studies which I have read. I have not reviewed them in the recent past, but I am sure, my memory serves me well. But there is a study in which metformin was given for patients with NAFLD, and they have seen significant changes. It has been given for obstructive sleep apnea, and they have seen significant changes with metformin and lifestyle measures for the improvement in sleep apnea. Metformin does improve in obstructive sleep apnea as per those 3 studies. At least I don't have it in the back of my mind right now, but I have definitely read about them. Metformin does improve in the obstructive sleep apnea, according to these small case series at least.
Right. So we mean to say that insulin resistance is the villain, and metformin is always the hero that comes to save the organs affected by insulin
It
resistance.
unfortunately, it's not only metformin. It has to be metformin and lifestyle. That
Lifestyle,
that has
of
to
course.
be. It's very important. If you are taking metformin and continuing to have a bad lifestyle, not exercising and eating whatever you want at whatever time, metformin is not going to be able to help you. It has to be combined with both.
Yes, agree totally. So my next question is something that I've always had curiosity about. It's about metformin and mind. I have read reports about the benefits of metformin in depression and Alzheimer's disease, and also contradictory reports of metformin having side effects, CNS side effects. So how do you explain that, or have you come across anything like this in your clinical practice?
Long-standing metformin will cause B12 deficiency. So there is a definite concern as far as using metformin continuously and not checking and not supplementing B12. And B12, as we know, is the most important vitamin as far as the central nervous system and peripheral nervous system is concerned. So long-term use of metformin can do both. It can either worsen the CNS symptoms, especially cognition, if you are not supplementing B12 after a particular time, if you're using metformin continuously. But if you're using metformin and giving B12 perfectly, just like all the other areas of the body, atherosclerosis towards the brain is going to improve, and therefore any vascular dementias or any other thing will improve over the long period of time. But it's a very gray zone. I don't think we have enough studies to say either this way or that way. Metformin, there are a few studies here, there are a few studies there, as you yourself have mentioned. I don't think we should be in a position to comment in a public forum as to what it actually does for long-standing dementias, because there are contradictory reports and there is no particular guideline on what metformin should be done in these particular patients.
Right, sir. That's actually
Yeah.
very clear. So thank you. Now we have spoken about all the metabolic syndromes. Coming back to diabetes, now we know that in India, metformin has been officially approved for use in high risk people with pre-diabetes to prevent
Yes.
diabetes. Um,
Correct.
of course, along with lifestyle modification, or if lifestyle modification does not work for 3 to 6 months, metformin is approved to be taken in pre-diabetes. What are your thoughts on the same?
So, to be very frank, I have been using it as an off-label indication to prevent diabetes for a very, very long time. Which same. First, we'll obviously ask people to do good lifestyle modification. If it doesn't work, we should be using metformin. Metformin, as I told right in the beginning of the talk, it addresses the basic pathophysiology characters that are actually leading to diabetes or worsening the type 2 diabetes. So, metformin in the use of pre-diabetes is a logical a way to treat diabetes. Of course, it cannot be a substitute for not exercising. This also I keep telling. So if you're taking metformin, you cannot stop doing diet and exercise. It has to be a combination of diet, exercise, good sleep, little bit of
Right.
meditation. Definitely, pre-diabetic outcomes are prolonged with metformin. We have data to suggest that. The DPP trial has been there. It has good number of patients from India actually. So definitely we should use metformin. It has been approved and we should use it.
Right, sir. Thank you. The saga of metformin will always continue, and there are so many topics and therapeutic effects of metformin that can we can go on talking about. But now time has come. I would like to ask you any concluding thoughts that you would like to emphasize on.
Yeah, so I said metformin. You should be judicious in the use of metformin, and don't have a misconception that using metformin for a long time is actually harmful and all. Metformin is a very useful drug. So number one is always stressing on lifestyle related changes, that is diet, exercise, and de-stressing. But those conditions which are precipitated by insulin resistance, especially type 2 diabetes, pre-diabetes, PCOS, NAFLD, do not hesitate to use metformin, because there are definitely much the benefit to risk ratio is probably 100 is to 1. Actually, that much benefit is there with metformin compared to any risk it might have in as far as GI intolerance or B12 deficiency is concerned. So do use metformin judiciously. It will help your patients only in the long run.
Thank you so much, Dr. Santosh, for being with us, for giving us all the clinical pearls on metformin in diabetes and beyond diabetes as well. I'm sure all these points, all these aspects of diabetes management can be taken up by the physicians to make India, the diabetes care capital of the world, and to treat our patients with diabetes and comorbidities with as much ease as possible with the wonder drug metformin. So, thank you, sir. Thank you to everybody for logging in, and keep watching these chat shows for more information. Thank you. Thank you.
All right. Good night. Bye.
Thank you, sir.